Um, we're going to get started. My name is Megan Phillip. I'm the Executive Director of HC3. Welcome to today's virtual discussion. HC3 is a coalition of healthcare leaders and organizations that are influencing change in our local communities, and we're looking forward to having a really robust discussion with our experts today. So today we are starting what will hopefully be the first of a few important conversations around the coronavirus. The city of Chicago and state of Illinois have faced many challenges over the past several months, and we are starting to see the light at the end of the tunnel with phase 4 starting on Friday. And in order to prepare for the surge or potential wave of cases and thinking about how we move forward, we have to look at our past. So today we are convening to review some of the challenges and successes that we have combated over the past few months. A few housekeeping items for today. Today's session will be recorded and shared after the event. So if you don't receive that link or need anything, you can feel free to contact me. If you have any questions, please use the chat function, which will be seen directly by our panelists. So with that, I'll go ahead and get started. So today's discussion will be moderated by David Smith, who is the CEO and founder of the Healthcare Council and Third Horizon Strategies. And Dr. McKinney is the CEO and Executive Director of the Illinois Medical District, who during the crisis also served as a strategic resource to the state of Illinois by leading operations for the alternative COVID-19 sites. Dr. Casey is from Rush University Medical Center. He's an emergency physician and has been the acting chief medical officer during the crisis. And last but not least is Heather Nelson, Senior Vice President and the Chief Innovation Officer at UChicago Medicine. So without further ado, I will let David take it from there.
Great, thanks, Megan. And I'll reiterate our gratitude for Dr. Casey, Suzet McKinney, and Heather Nelson in taking time out of their busy, active schedules to join us. I think everybody that is dialing in and participating with us will come to feel, as we do at the end of this discussion, that these are three people in our city who are not only well equipped to have the dialogue, but have done really important work during this period and helping the city move forward. So thank you to the three of them. Just as a quick run of show, we'll go until about 1 o'clock. We will be taking questions. Megan, I'm so sorry. That's going to be through the chat feature, I believe. So we would invite folks that as you have questions through the interaction to use that feature to ask the question. You can direct those directly at Megan Phillip. I believe unless you specify, you'll say it to everybody, which is okay too. We'll gather those questions and I'll have them fed back to me as we're having the discussion. And as I said, we'll conclude promptly at 1. I thought before we get started, I would just share a couple of quick thoughts. One, just on the council itself, and then 2 on the subject matter. And I'll try to be quick because we all want to hear from our 3 colleagues here more than me. For the Healthcare Council, for those of you that have joined and are members with us, we want to continue to just emphasize our gratitude for your participation here, but the ongoing support that you've rendered. In early March, we wanted to take a bit of a posture to just pull way back on all things pertaining to the council, and we made a very deliberate decision to not add to any of the noise that the environment was creating or create any distraction. And with that, we have been just a little quiet and quietly connecting with many of you during that period. That said, the initiatives, the programming, the various things we all collectively want to pursue through 2020 and into next year are still active, and you will be receiving additional information and seeing that activity continue to gain momentum again as we make this transition from at least one phase of this moment to another phase of the moment. I want to talk just a bit and maybe provide a couple of my own thoughts just about what we've all been through, and I don't want to belabor that point because I know we've all had various experiences, but I think there are some really remarkable things that have come from this moment that are maybe ubiquitous across the country, but certainly I think germane to our city. And three things I think in particular that I've observed that I think are worth noting. I think the first one probably comes from a discussion I had about a month and a half ago with Governor Mike Leavitt, Secretary Leavitt, and still have a chance to check in with him occasionally, and needed to seek his counsel about a different topic. And we had a little extra time, so I just said, "Hey, what is your take? What is the federal response adequacy in your mind, and what do you believe is important to note with states, and so on and so forth?" And I'll dispense with the things that may be slightly more political. But one thing he said has just stuck with me, and at first it kind of haunted me, and now it's excited me. And he said that during his 4 years at the Department of Health and Human Services, he managed through a couple pandemics, and that really triggered the federal government to realize it was not prepared for something like this. And so he spent a lot of time organizing tabletops and doing things to get the different departments and agencies wired to work together in a different way. And he said, through those pandemics, those were easier pandemics because we could trace them, we could contain them in a way that this virus does not respond to as easily. He said, but I spent time studying the global history of pandemics, which is fascinating. And he said, there'll be a pandemic of some sorts every few years, and it'll be something like SARS or swine flu. Again, easy to track, easy to trace, easier to contain. But about every 125 years in human history, there's something like COVID that is highly transmissive. It moves quickly and takes a long time to contain, and also comes with an extraordinary toll on human life, as we've seen with this virus. And he said the one kind of common feature about that, once in a century moment, is that it changes everything. It changes the culture, the politics change, and the political structure. The economy changes, and the way we organize resources. But the biggest thing is that the social compact of the world and of citizens in a community tends to change. There's a significant inflection point that comes with that. And I don't know that any of us really know exactly what the longer term implications of that are for us or for Chicago yet, but I certainly in my own personal life and professional life have felt those changes. And so that is one thing I've thought of. The second is I have been blown away with how rapidly a health system that takes forever to do anything has been able to hit the gas and fill gaps in ways we would have never thought imaginable. If you look at the adoption of telehealth, or a shift to interacting with patients through asynchronous capacities, or a litany of other use cases. These are things that would have taken years in legislation and lobbying and all kinds of things, and we did it in days. And it's demonstrative to me that our system is more than capable of doing the things we have to do to improve care. We just don't do them. And there's reasons for that, and that's not to denigrate or downplay the importance of those reasons, but it's an important thing to observe, and it's important to look at the incredible collaboration that has taken place throughout our community, through all of you. I think the third thing that is important to that I have at least observed is, and I don't know how many of you felt, but I have spent the last 5 or so years of my life using the term vulnerable populations no less than 40 times on any given day. I wake up and I think about it, and I go to bed and I think about it. And those of you that know me know that that's not lip service, but that's truly a passion. But it's easy to forget what that feels like. And in the early March timeframe, there were, I suspect, about 7.5, 8 billion of us that all felt kind of uniquely vulnerable at a certain moment of time, very uncertain of what the future would bring, uneasy about our families and our loved ones. And it's important to note and to foster that feeling, but it's also important to note that many of us have not lived through the depths of vulnerability that so many others have. So it's a useful tool and instrument for empathy, and we should keep that with us and practice it. We should also acknowledge what we all know as the egregious disproportionality of how this virus has affected members of our community, particularly community members of color, those who do not have the same level of economic means, and so on. And if nothing else, that should continue to be a clarion call for all of us as we move forward in the work we do together as parts of the council or individually in our institutions. There's a lot of other implications to think through. What does the social compact change mean? As we go through the financial implications of COVID and a recession, and we see the duress on hospital system finances, does that present an opportunity to catalyze some of the faster changes that we've seen take place? There's a lot to think through and talk through. So we'll have a chance to do a little bit of that today. And with that, I'd love to just jump into the discussion. And again, for anybody that's joined as I was speaking, we would invite you to ask questions using the chat feature. And Suzette, let me go to you. Megan gave you an introduction, and I could read your long bio, but you'd roll your eyes and I'd feel awkward. So we're just going to jump into it. Suzette, you played a really important role in the city. And by the way, what a terrible time to be a first term mayor for a city like Chicago.
Yeah.
That notwithstanding, I think Mayor Lightfoot has demonstrated exemplary leadership, and along with our governor, has been cautious and thoughtful and deliberate about their approach. Suzette, talk a little bit about what your role has been during this period, and some of the observations you've made about the city and where we're going from here.
Sure. So good afternoon, everyone. Thank you so much for being here. It's wonderful for me to be with you all this morning, or this afternoon, I should say. In terms of my prior role, so I currently serve as the CEO of the Illinois Medical District, but prior to that, I was a deputy commissioner for the Chicago Department of Public Health. And in that capacity, I oversaw our Bureau of Public Health Preparedness and Emergency Response. I stepped into that role in late 2008 and officially took the role in January of 2009. 3 months later, H1N1 occurred. So that was also a pandemic, certainly not of the same scope or scale that we're seeing currently with COVID-19, but we had actually been studying pandemics and preparing for pandemics since 2006. So David, some of what you spoke about in your conversation with Secretary Leavitt about lack of preparation, in Chicago, we had been doing a lot of that work because we had started in 2006, because we had the experience with H1N1 in 2009. And then beyond that, we also had the Ebola experience in 2014. And one of the things that I led along with my team was beginning the process of developing a comprehensive warehousing strategy for the city of Chicago, such that we could acquire and maintain important equipment, including personal protective equipment and other resources that our city would need in the face of one of these types of disasters. And so, you know, when Ebola started, we had certain types of equipment in our warehouse already that we could deploy to hospitals across the city to assist them until their supply chains could come in. And so I continue to be very, very proud of that work. I certainly don't envy Mayor Lightfoot in the sense that she came into her role as mayor, and just within a few months, we had COVID-19 to start. I will say, I think she's done a fantastic job. I think the city has done a fantastic job in its response. And I feel pride, not only because of it's the city that I live in, but also because I feel like I had a part in assisting with the preparation that helped them start out on the foot that they did. In terms of COVID-19, I was actually asked to come in to assist the state of Illinois in its COVID-19 response. And when I initially started that work in the first week of April, I was brought in to serve as the operations lead, the non-clinical operations lead for the state's alternate care facilities. And so the audience today may have heard about these 5 facilities. The most famous has been McCormick Place, which we worked with the Army Corps of Engineers, the U.S. Army Corps of Engineers, as well as a large construction team to convert several halls within the McCormick Place into patient treatment areas. And the capacity that we developed there was for 3,000 beds at McCormick Place. And then separate and aside from McCormick Place, there were 4 shuttered hospitals in various areas across the state, where we also worked with the U.S. Army Corps of Engineers and a different construction crew for each hospital to get those facilities back to a level where they could accept patients as well. And so across those other 4 facilities, we developed a capacity for about another 2,500 beds, patient care beds. And the idea behind the alternate care facilities was really to serve as a resource to decompress hospitals. If hospital, ICU beds and critical care beds became completely full and there was an opportunity to move less acute patients out of the hospital setting and continue their care at one of these alternate care facilities. What I will say moving beyond that is I've also now taken on some additional responsibilities to assist the state with its congregate care settings, which include nursing homes, jails, as well as homeless shelters.
Suzet, thank you. I want to just ask one quick follow-up on that, and then we'll move to some thoughts from Dr. Casey. So obviously we're watching around the country right now with caution and concern as certainly case rates increase from what they had been, and with some concern that mortality rates may increase alongside that. We don't necessarily need to talk about the other markets. I think here in Chicago, we are all, as we enter a new phase of reopening, we are all very cautious about a subsequent wave in the fall or some other kind of surge that would take place between now and then. So if we were to assume that that a vaccine or therapy or anything else were still a little ways off, and we still have to be in a mode of social distancing and contact tracing and so on, what is the city's kind of general preparedness? If we got hit with a big wave 2 in the October, November months, what do we have in place now that we didn't have in place before? What do we need to still get in place to be even better prepared for that potential?
So what I would say, the first thing that we have is experience with this first wave of COVID-19. You know, when the pandemic originally began, as with most novel strains of disease, there really wasn't much that we knew about it at all, not from an operational perspective, but also not from a scientific perspective. If you know anything about the behavior of pandemics, you know that they typically circle the globe in waves, typically 2 to 3 waves. And so from that perspective, there's no reason to think that we won't see a second wave. But I think what I would stress is that in the absence of a medical countermeasure, whether that's a vaccine or an antiviral drug, it is the social distancing measures and the masking and other non-pharmaceutical interventions that we really have in the public health toolbox to be able to protect ourselves, protect our residents, and the citizens of the city of Chicago. I think some of the other capabilities that we have in place, you know, the city has a very robust epidemiology and surveillance mechanism such that disease can be tracked. I think the city's health department has excellent relationships with the hospitals and healthcare systems across the city. There have been some significant efforts put in place specifically to reach some of the more at-risk populations, including African-American and Latinx communities. And I think the other thing that we see now, the capability that we have now, is also a robust contact tracing operation. Some of the audience members may have heard just a couple of weeks ago that the city was releasing an RFP for an entity to assist with contact tracing. And that's really critical. In addition to testing and the epidemiology and surveillance, it's really critical to identifying not only where disease is, but other areas where disease could be based on close contacts of folks that are infected. And I think the other thing and the final thing that I would say is, here in Chicago, as well as in the state of Illinois, our elected officials, our leaders have been very clear about following the science and the data. And that's very, very important because their actions and even the restrictions that have been put in place that so many of us don't like, those restrictions have been put in place based on what we're seeing with the data and in the science. And my concern about some of these other markets is, you know, we aren't even out of the first wave and we're still seeing large surges of disease.
You know, I'll quickly attest to that, and then we'll make the pivot. About a month ago, I took a pretty long road trip around the country to do some personal things and seek out some family, and was obviously had, you know, a box of 100 masks and had my hazmat suit and everything else so I could keep myself and others protected. But going from community to community in the east, the southeast, the southwest, the Intermountain West, there was this range where some communities took this very seriously, and then there were communities where I would be verbally accosted for wearing a mask as I walked into a gas station. And I'll be honest, and I'm not blowing smoke here, coming back to Chicago and, you know, still occasionally coming downtown or being in my own neighborhood, I've been proud of the way most of us have reacted to this and the seriousness under which we've taken it. And I don't know that that's a universal statement. Others may have other experiences, but again, it's gratifying to be in a city where leadership gets it, and I think the community, as much as we don't love some of these things, we recognize the importance of them to protect ourselves, our families, and the others around us. Dr. Casey, a special acknowledgement should go out to you, not only for the service you and your colleagues have rendered on the front lines of this period, which none of us can have empathy for, because many of us did not have that experience and can only imagine the mental and physical and emotional strain of that. But you're also a new chief medical officer, and as you said earlier, nobody advised you this was coming as you took this role at a big place like Rush. Maybe talk just a little bit about the Rush experience through this period, how you mobilized, what things you changed, and maybe kind of a similar question as that to Suzette. How are you thinking differently and preparedness about the potential of a wave 2 or anything else unexpected than you may have thought prior to this?
Sure, absolutely. Thanks again, by the way, David, for having me today. Really appreciate the opportunity to share some of these learnings, because I think that's critical, of course, to how we move forward, is really taking this opportunity to debrief a little bit and share the learnings across the institutions across the city. So I'd say to your question about, the general approach, I still, we were actually just talking about it last night. I still distinctly remember it was February 28th when we kind of pulled together as a leadership team, and a small group of us on the operational side, we had a discussion about, this tsunami is headed our way. We certainly at that point only had a couple of cases here in the Chicagoland area. But we made the decision, at that meeting, we made a couple decisions. One was that we're never going to look back and say that we were over prepared. Seeing what was beginning to emerge in New York, we realized that we couldn't be prepared enough, and every step that we took really had to be focused on being feeling over prepared, and kind of hoping for the best while being prepared for the worst. So that was a philosophy we followed throughout every step really we took. From that day forward, the very next morning, we opened our command center, which was a really seemed to be early for a lot of us to get that kind of rigor together. And we really, through the command center structure, every single day, twice a day, we're meeting and advancing our preparation plans, well in advance of beginning to see a fair number of COVID patients here at Rush. So that was one big step in our preparation that I think in retrospect, we all looked back and said it was a great decision in retrospect, because we really felt prepared. And I think that confidence came through to staff as well. And staff really, as a result, felt prepared because we were being incredibly proactive and transparent with our preparation throughout, as opposed to reacting as we began to see patients come in. So that was one important learning. I think the other thing that we did in a preparatory effort was, again, trying to learn the lessons that we had seen emerge out of Seattle, out of the Northwest in Seattle, the lessons that were beginning at that point to emerge out of New York. We were concerned about our communities that did not have the same resources that we'd be able to bring to bear. So, I think one of the real advantages of working in an academic medical system is the number of resources we have around critical care, or the therapies we can provide, like ECMO, which is essentially a heart-lung bypass. So we also made a decision early on to proactively reach out to a lot of our community hospitals as part of our West Side initiative, a lot of the hospitals that we deal with on an ongoing basis on the West and Southwest sides, to establish that we are happy to take care of any patient any patient that's sick that you can't take care of. That's really what we're here for. And a result of that proactive outreach, we transferred in about 160 plus patients into Rush during the period of March through about mid-May, that were all COVID positive patients. So again, it was part of our planning from very early on, and it was very intentional that, in order to really do well with this as a community, we can't, just look at this as the medical center. We really got to be able to support the entire community, the entire city, to move forward on this. And we also made that clear to both the city and the state, and had, extraordinary collaboration with both the Chicago Department of Public Health, as well as Illinois Department of Public Health, with nearly daily phone calls to really try to help orchestrate some of the response as a city. Because I think that would be one of the learnings moving forward. It was amazing to see all these institutions come together in a number of different ways and really take care of just an overwhelming amount of patients and have such amazing outcomes. But I think there are still some opportunities to even better coordinate that response and really unify the city as we move forward in responses to a lot of these different, whether it's a pandemic or something similar.
And Dr. Casey, in the beginning of this period, I know we were all seeing a lot of data sources and information sources pointing out the lack of PPE and ventilators, and you saw images on the news of makeshift gear that people had. Can you just comment a little bit on the physical resources you really required to take care of patients? How readily available was that? And in keeping with these opportunities to better prepare, the last point you just made, are there areas where we need to be more thoughtful or diligent in having the physical equipment required to meet worst case volumes?
Yeah, that's a great question. And, I think we were fortunate in that, as Suzette discussed, on the heels of Ebola, we realized that PPE was critically important as part of our emergency response. So we had actually, around 2015, tried to build up a bit of an inventory around the different types of PPE. So I think we were fortunate in that regard that when we pulled together as a command center in early March, we were in, fairly good situation in terms of the critical pieces of gowns, masks, N95s, the different pieces you hear about. That being said, as this played out, we had an extraordinarily large volume of COVID patients we were taking care of. So there were times that we were having some really thoughtful conversations around, do we have the right PPE in the right places? Are there ways that we need to change our PPE policies? How do we support our system, to make sure that we're both using the PPE thoughtfully at the medical center, but also with our system hospitals and our community hospitals. So there were a number of times that we actually sent PPE to other institutions that truly were down to their, down to the last threads in terms of PPE. So I think some of the pieces that we learned from was very early having the command center on a daily cadence, having accounting in days of the number of days of PPE of all those critical supplies that we had, whether it was, the lab media at one point became the viral transport media for testing for COVID became a critical resource. So there were a lot of different pieces that we tried to identify early on, make an all-inclusive list of all the things that we thought might be in short supply. And then we also used our analytics. So we have a great analytics team here at Rush led by Dr. Hoda. And we actually really used a lot of predictive analytics to look at our burn rates and when we anticipated the shortage, which allowed our supply chain operators to really be able to identify well in advance the type of PPE we'd have to order. And certainly we used, we resourced more deeply than we typically would in terms of the different places we saw PPE and the different approaches. But we tried to also always make sure that for each of those critical resources, we had identified a backup plan and a trigger when we go into that backup plan. So, the example in PPE was around the cleaning of gowns. Is there a point, or a cleaning of masks? Is there a point at which we would start cleaning masks through a resource the city had set up and start bringing those back into circulation for specific providers? So we never met that point, but we kind of made sure in that command center structure, we always had another outlet because that was really critical to making staff feel confident that we had the supplies. I will say that one other piece that relates to resourcing and PPE is, we struggled a lot in the communications early on with staff to assure them that we had enough PPE, because I think there was so much in the media, so much attention to these shortages. There were some sensationalism. Certainly, we had, in one instance, a news outlet, national news outlet that reached out directly to one of our residents trying to get pictures of empty boxes of gowns or masks. They were, so really trying to intentionally kind of blow up this story of shortages where there weren't, in fact, shortages. So one of the learnings we had is we were actually incredibly transparent with our staff with the amount of supplies we had. We had daily communications going out to all staff, and we actually started including the exact number of days left we had of each piece of supply. And the response from staff was overwhelming, that they really enjoyed that transparency and the fact that we were really telling them to the day exactly what we had left and if there were any areas about which we were concerned.
Heather, I'm going to do one more question for Paul and then jump to you, because I'm really excited to dig in on the information systems side of this. Dr. Casey, if nobody warned you, sometimes I go off script. This is one of those moments. So, but I'll keep it soft. Talk just a little bit about, so even like that last example you shared of something that was kind of, it was unique. It's not something you guys had dealt with before, and how to communicate with staff in this way, or media reaching out to sensationalize a topic. I suspect hospitals all over the community had similar experiences. Everybody was facing something. There's no playbook for how to deal with this, or no SOP that everybody could adhere to. What mechanisms existed for hospital leaders, whether it's an individual safety net hospital on the south or west side, or a big integrated system? How did you come together to share clinical observations, operational observations, human resources? What were those resources, and are there ways to make that better, or how would we maintain the good work already done?
Yeah, so two pieces come to mind. One, I think the Chicago Department of Public Health did a really nice job on pulling together on a regular cadence calls in which all the infection control, chief medical officers, whichever group they were targeting, were really getting updated. So interestingly, as a side anecdote, Dr. Layden, who's the chief medical officer at CDPH, I thought she did an extraordinary job really keeping that cadence. I happened to train with Jen about 15 years ago and didn't realize we had, not crossed paths until COVID made it almost daily conversations again around that coordination. So I thought the voices on those calls were great because it really was inclusive of hospitals throughout the area, not just academics, not just community. I mean, really a broad stroke of hospitals. The other piece that I would say, one of the gaps that touches on something you mentioned earlier was some of the gaps in certain neighborhoods and being able to really get reliable data on race and ethnicity through our existing lab testing systems, through the electronic lab reporting, became a gap that we identified with CDPH and with Dr. Layden. So we actually brought together a consortium of institutions to work on. It was a group of CMIOs, a group of chief medical officers, to work on a CDPH, a Chicago Department of Public Health data hub that would actually improve both the capacity reporting for institutions throughout the city, but also try to capture better electronic lab reporting. So better data on race, ethnicity, contact information, which at baseline was missing at about 20 to 30% of cases in which there'd be a test. There was no information on race, ethnicity to really know the impact in different areas, nor contact to be able to really get the contact tracing that Suzet mentioned is so critically important to making sure that we're prepared. So that was another instance in which we brought together a number of institutions throughout the city to look specifically at that problem and try to solve for what are the data gaps and how can we institutionally improve and help inform some of the public health policy around improving that for the entire city.
Thank you, Dr. Casey. Okay, well, now that the word data has been said, Heather, let's jump right to you. Let's talk a little bit about the IT infrastructure, and maybe I'll just start by asking. I made a point on the front end about the kind of remarkable rapid mobilization and this notion that we did things with tech that would have heretofore taken a longer period. Was that your experience as well? Did you observe that, and what have you seen in the city more broadly that gets you excited as somebody that knows the power of these tools?
Oh, thank you. Thanks. It's great to have everyone on the phone, and I'm so honored to be part of this panel. From my perspective, and the University of Chicago Medicine as a CIO, we've been working on our digital health strategy and our digital health transformation strategy for quite some time. And, talking to faculty and providers about what it means, what telehealth means to them and what it could mean for us, kind of fell flat for quite some time. Pandemic hits, guess what? Everyone needs to do video visits. Everyone needs to do. So if there's a silver lining in this pandemic, I will say it's definitely accelerated our digital health roadmap. And, as of, last week, we have done close to 60,000 video visits since, the beginning of April. And my teams, and I think I mentioned this, in IT, we're the people that take care of the people that take care of patients. And we had to be responsive and nimble. And while we had video visits on our roadmap and we had the vendors lined up and we had all these things, kind of teed up, we had to execute very quickly. And, some of the things we're now going back and optimizing, which because now we've got the groundswell, we've got the utilization, we've got the feedback, we know that it's not going to go back to 100% inpatient, in-person visits. We know that. We know that our workforce isn't going to come back, 100%. We're all going to be in the offices again. So not only were we needing to be responsive to the clinical needs and the technologies to support those, but as well as for the workforce, having, a couple thousand people that normally never worked remote, now work remote, making sure that they had the equipment to do their job. We had the bandwidth for them to be able to complete their job. I had to get all of our radiologists at home reading, and, Dr. McKinney and Dr. Casey will appreciate this. Some of the radiologist equipment, their monitors you can't buy from Best Buy. They're $40,000 a piece. And having to, go out to their homes, my team members who were concerned, having to gown up and go into someone's home and set up equipment. Our cardiologists are able to read. I don't know if my radiologists will come back. So really being nimble. And it wasn't, David, that it was new technology. It was all technology we either had in place or we were thinking about, and it was just getting it going. And as well as being responsive to not only the video visits, that patient engagement perspective, but we had to cohort patients quickly. I'm sure, Dr. Casey can appreciate this, is we had to, create ICU rooms and ICU beds that were med-surg beds or were in the ED. And the clinical engineering teams report into me. So my clinical engineers have been at the forefront of this from the very beginning and making sure that our monitors work, our ventilators work, and, quickly being able to work within our EHR and flip that bed to be an ICU bed. And then as our numbers continue to go down, thankfully, switching them back so that we could now get our ORs going again and making room for non-COVID ICU patients. So when we think about IT, it isn't just the bits and bytes and the EHR, it's everything behind the scenes. And I'm part of our HIC structure, as Dr. Casey mentioned. We started meeting back in January. And IT has a seat at the table, and which I'm most appreciative of. And we've been, meeting ever since, and we continue to meet every single day, doing the same things, reporting on the same data. I too appreciate that the city, stood up those data repositories because it truly has been collaborative. Competition went to the wayside back in early March. We're all in this together. We're here to take care of patients in our communities. And, we've also, reached out, as I'm sure Dr. McKinney and Dr. Casey have done, to nursing home facilities to provide testing there. My teams have helped stand up, our curbside testing, our curbside phlebotomy now, because we want patients to feel comfortable in coming in for procedures. And if they need that lab work, we've stood up, you can drive through, and if we can get your blood out the window, we'll do that. So being very creative and innovative. And what's nice is not necessarily having to ask for permission, and having the operational buy-in, which, for those of us on the phone that are from IT, sometimes IT is the tail wagging the dog, and we kind of have to pull operations along when it comes to new technologies or new workflows that are impacted by technologies. Having the clinical and business leadership and my partners just being out there and saying, can we do this? When can we do it? And I'm like, yes, 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 and yes, has just been outstanding. And I'm just so proud of my teams who have never said no. and have worked so many hours right along with the physicians and the nurses and the healthcare workers, you know, and in our organization, as well as being able to work so closely with our university partners, much like I'm sure Dr. Casey is, and some of the innovations that have come out of the research and the innovation arms of our organization.
Thank you, Heather. Questions are trickling in. I have two other questions, Heather. I want to just lob in your direction, and then we'll grapple with some of these coming in. Again, for those who weren't here at the beginning, we're scheduled to go till 1. As a rule of thumb, I'll take us all the way up to 1, but won't go a second over, even if I'm mid-sentence. So Heather, front end question, back end question. Let's start with a front end question. Let's say that today an FDA approved evidence-based vaccine fell from the sky, and we were able to administer that and at scale and very quickly get back to normalcy, whatever that's going to mean going forward. Based on the last 90 days of kind of sustained interactions our clinicians and professionals have had with patients and community members, how much of that is enduring through technology, and do any parts of that genie go back into the bottle, and do we go back to kind of a pre-COVID mentality and how we think about Zoom? I mean, I'm loving Zoom. To be honest, I've been on one airplane in 3 months, which is awesome. But how enduring do you think that's going to be in our field?
And that's a great question. And that's a question that, as we are wrapping up our fiscal year and thinking about our goals and objectives for our next fiscal year, digital health, which has always been, you know, a foundational component of our annual operating plans and our strategic plans, we have all said, you know, all of my peers, you know, our president, our dean, et cetera, there's no going back, David. You can't get that genie back. And while I'm sure Suzette and Paul and many others on this webinar today can appreciate, we're not going to have the capital to do as much as we had hoped to next year. So when we think about our digital health, you know, roadmap and our strategy and telehealth and video visits and telestroke and all of that stuff, it's not going to be as much about what's new, what are the next 3 new things we're going to do. It's how can we optimize what we have. So like I mentioned about video visits, we had some quick down and dirty things we needed to do. Now we need to take the time to really optimize it, really make sure we've got good metrics, we've got the outcomes we're hoping for, and so that we can sustain that and make sure that, you know, providers, care team members really feel comfortable with the technology. I mean, it was thrust upon them. Now it's going back and really measuring the utilization. What's great is we're getting reimbursed for it. I hope that doesn't stop. I hope the feds, you know, don't stop that, because that too, I think, has also helped to spur this along as well, that we've got the reimbursement. You know, a telephone visit's one thing, but that video visit is where the reimbursement is. So I don't think we could squeeze that genie back in.
Yeah, I suspect you're right. And I suspect we all have our own anecdotes and experiences. We have a family physician who has been in practice for 35 years and had just sworn he would never do a virtual visit. And it was just anathema to him. And during our second or third interaction with him during this period, he said, I don't know why I haven't been doing this as long as it's been a thing. This has changed the quality of my life and the way I can interact with patients and the volumes through which I can do that. So obviously that's a multifaceted question that goes from policy to clinicians to patients, but I suspect you're right. Okay, the back end question real quick, and then I want to tackle some of these questions coming in. Paul talked a little bit about, you know, these information systems that have started to come together. Heather, you made mention of that as well. Well, we have known for some time in the city and state that we've had major information gaps because of how fragmented the delivery system in our market has historically been. What is your level of optimism, pessimism, neutrality about our ability to not only continue to improve on those systems, but to build on them in other population health management contexts, things that would let us have better line of sight on chronic disease or social factors, or the things we know are a measure of a person's health? I
think that's a great question. It's $1 million question. And I think for, you know, the CEOs of our major EHRs in this community, and I know Paul and I share the same EHR, that the genie's out of the bag too. I mean, the interoperability, not interfaces, but true interoperability has to happen. And these vendors have got to be more nimble. As much as we have had to be nimble in the deployment, they have to be more nimble and allow these systems to talk, because if they can't, there's going to be a vendor, and we know those disruptors out there. We know the Amazons, we know the Googles, we know the Walmarts of the world. There's disruptors out there, and it's going to happen. And some of this silver lining, not just about video visits, is about the interoperability and the sharing of data in a way that we, Suzet can probably speak to more. Getting data, back in 2014 was a lot harder than it was this time, but it's still hard. And I think that this industry has had to relinquish some of that in a very safe and secure manner. Don't get me wrong. We still have to make sure, we have safety in place. We've got privacy, HIPAA, all that good stuff. But I'm impressed with the fact that we've been able to do better data sharing. But more importantly, these vendors have got to be able to talk to each other. And because if not, health systems, they're gonna find a way to do it, because as patients, as consumers, we expect it. We expect it now. So there's no going back.
Well, I think one thing to take solace in is the incredible and fast work that was happening as a function of cures through ONC and CMS pre-COVID that started to lay some of that ground. I suspect, in keeping with the other parts of the conversation we've had, and Heather, the comments you just made, that we at least have a more fertile ground for that environment to flourish. Okay, handful of questions coming in. I want to get to this, so we're gonna do kind of a rapid response lightning round here, guys. And if we go over like 40 seconds, I'm gonna buzz. I don't have the buzzer, but anyway, we'll try and keep it succinct. So Suzette, maybe first question to you that came in was focused on vaccinations. I'm really interested in this question. And Paul, you may have a thought on this too, but I think that the general premise is, kind of end of year, beginning of next year is kind of the earliest where we might see an FDA approved vaccination. How is the city thinking about the distribution of that and the scaling of that in a way that is safe? Oh, Suzette, you're muted. And I could read lips, but I'm not going to.
I'm sorry. I didn't realize I was on mute. So I think the city has a number of mechanisms that they would potentially use for vaccine distribution. The first is through distribution of vaccines to physicians' offices and to hospitals. And then similarly, what we did in H1N1, the city back then set up a number of public vaccination centers. And so I could see, if vaccine supply was readily and widely available, that the city might implement a mass vaccination campaign, of course, ensuring that safe social distancing practices could also be employed in that type of situation. But those are typically the systems and the processes that the city would use to try and ensure that we provide vaccination on a widespread basis to anyone who needed it and or wanted it.
Paul, question for you. Thanks, Suzette. What is the impact, the enduring impact of COVID on clinical practice itself? How do things shift in the way doctors function, workflows, therapies? That's a big question for 30 seconds, but do your best.
Yeah, I'll do my best in 30 seconds. I think it's really been kind of the accelerant that's needed in many ways. COVID has for a lot of these practices. So Heather mentioned one, the ambulatory or drive-through testing. Most places are also considering, what else can we do drive-through, right? So that's a huge change in terms of anything we can do without actually having a patient come into the clinic. We've touched on telehealth certainly being the largest. I think the other thing that, the restaurant industry is also struggling with as well is that we really need a better pacing cadence to visits. So gone are the days of having, 10 people in a waiting room, in a small waiting room waiting for their visit. We really need to have that better on-demand model and better operational models for really queuing patients to come in, direct rooming. It's going to make us more efficient and make us get a lot of the non-value added time out of the system by necessity at this point to adhere to the social distancing.
A great answer. And I suspect will make you even better partners with the technology industry that can likely facilitate some of that. Heather, kind of a two-part question for you. As you've seen the proliferation of digital resources, where have you seen pushback, if anywhere? Who have been kind of the reticent parties, if they've been there? And did you face any challenges with certain parts of Chicago that did not have the right level of infrastructure for connectivity, broadband or whatever? Oh, Heather, you're muted, sorry.
Thank you. Can't read my lips. I think pushing back would be, our providers want this to be easy. We can't add one more thing. So as I mentioned, while we implemented video visits, now we're going back to really optimize and make sure that the workflow that, the MA can get the video visit started, that the MA can touch base with the patient, before the visit to make sure that they've got the app downloaded and they can, do everything that they need to do. So it's not so much pushing back, it's more, now this is just another level of creating that ease of practice for the providers and for the care team members in a digital way. And, I think all of us experienced, the connectivity issues with the amount of times we're all using Zoom. I think, I think, back in April, late April, we had the Zoom bombing. So I think the vendor, they have done a ton to make things more secure. We just pushed out, mandatory passwords for all Zoom meetings. And I think that was really, I haven't heard, knock on wood, that, we've had issues. And that's just part of my preparation to support this was to increase our bandwidth, spend the money and make sure that we had the technologies to support it up front. And instead of waiting and reacting, we tried to be as proactive. And again, knock on wood, we haven't had those issues. Even with radiologists reading, large image sets from their homes. Now, granted, they wanted me to run fiber to their homes, and I told them no. But they've done a good job, and we continue. We monitor it daily, hourly, minute by minute. All of our connections across our health system.
So Heather, I know you're going to have a hard stop at 1.
Yeah.
And I've made that commitment. So I'm going to sprint to the fish that I'm firing more, but you're super on this. Okay, so be ready. I love this question from Erica Isaacs because it's so important. Jails, prisons, getting the crud kicked out of them. John Oliver did a big thing on this Sunday night. What are we doing in Chicago to try to address that?
Yeah, so more so, what are we doing across the state? What I'm seeing is that jails are testing residents, testing folks that are living in the jails, and where people are identified as being positive, they do have separate areas where people can quarantine while they recover. And if and when necessary, if someone needs to be hospitalized, then they are also being hospitalized. But I think one of the most encouraging things that I'm seeing is coordination across the system here in the state, coordination with the state health department and with other partners to make sure that protections are in place.
Wonderful. Well, we thank you, Suzette. We're at 12:58. I'm going to ask one final question, but you only get to answer with a number, so we can go really fast. So on a scale of 1 to 10, this time next year, 10 is that we are out of the woods. We are transforming the system. The sky is blue. Chicago will never have another winter. Like the world is markedly different than it is now. And 1 is there's tires burning outside of our buildings and hospitals, and things went in a totally different direction. How optimistic are you about, even though there's been a tremendous toll on all of us and a tremendous amount of human suffering through this period, how do you feel about our city system as we move forward on that scale? Heather, you go first.
I would say, I'm going to be neutral. I'm going to say 5 to 6.
Okay. Paul? Oh, you're muted, Paul. 7?
Yeah, you couldn't lip
Yes,
reading.
that's what
Yeah.
you're-
Yeah, I'm an optimist. With 7, well, I hope for 7.
Okay, Suzette?
I'm even more optimistic. I'm thinking 8.
Okay. All right. We're netting out around a 7 here on average. Well, to the 3 of you, thank you so much for spending your time and expertise with us today. For those that dialed in, thank you for joining us. Megan, give you the last word.
Yes, thank you all so much for joining us today. Thank you to our expert panelists and for David to moderate this important discussion. If you signed up via the Eventbrite, then you'll be hearing from us about future events. And if not, you can reach out to me at Megan, MEGHAN, at HC3.health. Thank you all.
Thank
Thank
you.
you. Bye.